sir.
Good evening.
My topic is snake bite and management, sir.
Hmm.
Snake bite is an acute, life-threatening, time-limiting medical emergency. So it is a preventable public health hazard often faced by a rural population. There are three major families of snakes, which are Elapidae, which consist of cobra, krait, and coral snake; Viperidae, which has vipers; Hydrophidae, which are sea snakes. So most common Indian varieties are cobra, Indian krait, Russell's viper, and saw-scale vipers. Clinical features: the signs and symptoms of snake bite follows four main categories, which are divided into progressive weakness in case of neuroparalytic, bleeding, myotoxic, and painful progressive swelling. But the clinical presentation varies with age, size of the patient, species of the snake, number and location of the bite, and quantity and toxicity of the venom. So if the patient has the history of bite, patient can present asymptomatic because 70% of the snakes are non-venomous, or sometimes the enough venom is not injected in case of dry bite, and sometimes it may take hours to present in case of krait bite, and renal failure and internal bleeding may be underway. If the patient is symptomatic, then it could be divided into four categories: neuroparalytic, suggestive of cobra or krait bite, which can be said as 5 Ds and 2 Ps: dyspnea, dysphonia, dysarthria, diplopia, dysphagia, and 2 Ps, which are ptosis and paralysis. Later, it involves the skeletal muscle and the intercostal muscles, leading to respiratory paralysis. In case of vascular toxic, it can have both local manifestation and systemic manifestation. Local manifestations like local swelling, bleeding, blistering, necrosis, pain at the site of the bite, and there will be absence of peripheral pulses in case of compartment syndrome, painful regional lymphadenopathy. In case of systemic manifestation, starting from subconjunctival hemorrhage, epistaxis, gingival bleeding, patient can have GI bleeding and perrectal bleeding. They can have AKI, and in severe cases, they may land up in DIC and shock. In case of progressive painful swelling, which is suggestive of Russell's viper or saw-scale viper, this indicates of local venom toxicity. Patient will have local manifestations like necrosis, blisters, pain, compartment syndrome. In case of myotoxicity, which suggestive of sea snake bite, patient will have muscle ache, swelling, involuntary contractions of muscle, passage of dark brown urine, cardiac arrhythmia due to hyperkalemia, and acute kidney injury because of myoglobinuria. If the patient has no history of bite, we may consider it as occult bite in case of krait, where there most of the time there will be no bite mark in case of krait bite. So patient will be normal the previous night, and it usually happens in the night during sleep. And in the morning, they'll develop severe abdominal pain, persisting vomiting, then may lead to paralytic symptoms like ptosis and respiratory distress. The diagnosis: if the patient comes in a non-critical, stable way, or if the patient comes in a critical way after stabilization, we have to do this diagnostic stage. We have to take a brief history of snake bite, the circumstance of snake bite and the time of snake bite, history of progression of local or systemic symptoms, history of urine output, urine since the bite, and other symptoms which we discussed in the clinical features. Examination, which include the site of the bite, any signs of local envenomation, and examination and vital should be recorded. We have to check for the distal pulse. In case of pregnant female, we have to look for uterine contraction and fetal heart rate. We have to look for any signs of severe snake envenomation like rapid extension of local swelling, early tender large lymphadenopathy, visible signs of neurological impairment, early spontaneous systemic bleeding or local site bleeding, passage of dark brown urine. Then investigations: a simple bedside diagnostic test is a 20-minute whole blood clotting time. A few ml of fresh venous blood is placed in a new, clean, dry glass vessel tube, and it is left undisturbed for 20 minutes. Then we have to tilt it, but it should not shake the glass bottle. If the blood is clotted, then the patient has passed the coagulation test. No anti-snake venom is required at this stage. And the test is repeated every 6 hours. At any point, if it is not clotting, we should consider administering anti-snake venom. Other investigations include hemogram, increase in hemoglobin in case of hemoconcentration by capillary leak, decrease in hemoglobin because of bleeding or anemia or hemolysis, increase in neutrophil suggestive of systemic absorption of venom, decrease in platelet because of viper envenomation, and RFT serum electrolytes to rule out AKI, LFT and coagulation profile to rule out coagulation abnormality, urine examination, routine ECG and chest X-ray, and if indicated and if the patient presents with signs of severe envenomation, acid blood gas analysis, fibrinogen, fibrin degradation product, serum creatinine phosphokinase are indicated. Management includes if the patient arrives in a critical situation, a rapid clinical assessment includes CABDE approach. We have to look for circulation, airway, breathing, disability, exposure, and environment. We have to establish a large bore IV cannula. Urgent resuscitation is required in case of profound hypotension and shock, in case of respiratory failure and sudden deterioration, or if the patient has cardiac arrest. They require urgent ventilator management, ICU care for volume replacement, pressure support, dialysis, and infusion of blood and blood products. After stabilization, a detailed clinical assessment should be taken and all the patients should be kept under observation for a minimum of 24 hours. Anti-snake venom, routine use of anti-snake venom is discouraged as it may lead to an adverse allergic reaction, but do not delay or withhold for a deserving patient. It is available as a polyvalent vaccine. It is in the two form, lyophilized powder form and the liquid form. It is usually given by intravenous route. Avoid intramuscular route and local infiltration of anti-snake venom. And the rate of infusion can be gradually increasing because it will lead to allergic reaction and in the presence of medical personnel. Epinephrine or adrenaline should on up in readiness before starting anti-snake venom. And the dose of anti-snake venom is usually 10 vials as a loading dose. Then after 6 hours, we have to repeat it with the 10 vials. In case of neuroparalytic and if the patient is not improving within 1 hour, we can repeat anti-snake venom after 1 hour. For vasculotoxic snake, it is suggested to have a low dose infusion therapy where the loading dose is given as 10 or 6 vials over 30 minutes and followed by infusion of 2 vials every 6 hours. We should monitor all the patients whom anti-snake venom is administered every 5 minutes for first 30 minutes and 15 minutes for 2 hours to maintain strict intake and output chart. Note the color of the urine. Victims who arrive late, patient with ptosis or respiratory failure AKI, we have to continue the respiratory support and we can administer the anti-snake venom as the same dose. Consider atropine and neostigmine infusion in case of ptosis or pharyngeal muscle palsy. For pregnant female and children, the dosage is same as that for adult. Even though the children have a lesser weight, but the amount of venom injected is same as that of adult. So the dose of ASP is same for the children. Early anaphylactic reactions due to complement activation by the ASP is common. So intradermal testing administered 30 minutes before ASV. And the drug of choice for anaphylactic reaction is adrenaline. Other supportive treatments include analgesics such as paracetamol or tramadol. NSAIDs and aspirin should not be used. Consider giving antibiotics and tetanus based on the wound. If it is a bad wound or a cellulitis, we can consider giving antibiotic and tetanus. Discourage the use of heparin and antifibrinolytics. Surgical management after stabilization, the patient can plan for craniotomy in case of intracranial hemorrhage, debridement of nephrotic tissue, and fasciotomy in case of compartment syndrome. Finally, the first aid treatment guidelines for the bystanders, it should be carried out immediately. We have to check for the history of snake bite, look for evidence of snake bite, reassure the patient, Immobilize the limb in the same way as the fractured limb. Do not block the blood supply or apply pressure. Do not apply tourniquet as it may lead to gangrenous limb. And also on the release of tourniquet, it may lead to a massive neurotoxicity or embolism or profound hypotension. Patient should be in the recovery position to protect airway or decrease the risk of aspiration. Patient should be nil by mouth. Avoid any traditional remedies which increases the risk of infection. Remove shoes, rings, watches, jewelry, any tight clothing which can act as a tourniquet. Just undisturbed. Do not wash the wound or interfere with the bite as it may increase risk of infection, increase the absorption of venom and increases local bleeding. Do not apply or inject anti-snake venom locally. Avoid cutting and suctioning the wound as it may increase the risk of infection and bleeding. Transport to a higher health facility where anti-snake venom, mechanical ventilator and dialysis facilities are available. Thank you, sir.
I thought you will first mention the first aid and then go on to the management, because usually that is the way you must start, because it is whenever the snake bite is suspected, transportation of the patient from the site of occurrence to medical center is very important. And most important thing is patient should not be made to walk or drive a vehicle. You should be always made to lie down and transported only in a stretcher or in a vehicle to prevent the venom getting absorbed faster and producing the bad effects of it.
Yes, sir.
Otherwise, you have covered most of the points, and